Hello, good afternoon, everyone. This is Dr. Mukram Ali Faridi. Today, I hope you had a very good weekend. So, this is a recording for a lecture, Chemotherapy and Radiotherapy in Oral Cancer Management. This lecture was supposed to be taken today, but because of extended holiday, so this lecture is been recorded. And I had already informed your group leader regarding taking the class. The answer which she had given, Dr. Manar had given me that record the lecture. If ever you cannot understand anything, you can ask me anytime, any doubts. And even if you want me to take the lecture, just fix a time, I can take this lecture in the classroom. Okay, so I have simplified this lecture so that even by looking at this lecture you can understand it. Okay, so let's start with chemotherapy and radiotherapy in oral cancer management. So being a dentist, why do we have to study this chemotherapy and radiotherapy? We will see in our further slides what is the importance of these in the for a general dental practitioner to know. Okay, so these are the contents of the lecture. Here I am not only taking management of a patient undergoing chemotherapy, but also management of patient undergoing radiotherapy. The important thing here is that you should know the management of patient before he takes chemotherapy, how a general dental practitioner can manage those patients, and during chemotherapy and after chemotherapy, how are you going to manage these patients? Manage means managing oral cavity, managing oral complications. It is same as in radiotherapy too. Management of patient before radiotherapy, during radiotherapy, or after radiotherapy. In further slides, it will be more clear to you people. Okay, so let me start with a question. What is the importance of chemotherapy and radiotherapy for the general dental practitioners? What is the importance? We as a general dental practitioner or dentist, do we prescribe chemotherapy drugs or do we refer the patient for radiotherapy? This is the question. So let's start the lecture. Okay, before I start, let me just introduce you to the basic terminologies. You already know it. What is a cancer? A disease caused by uncontrolled division of abnormal cells in any part of the body. And what is metastasis? The cancer cell can break away from their original site, travel around bloodstream and lymphatic system to other parts of the body. That means a cancer is in one part of the body, by blood and by lymphatic system or drainage, it will travel to different parts of the body. Understood? Now, these are the different modalities for cancer treatment. That is surgery, radiotherapy, and chemotherapy. I did not add, there is one more new modality of treatment is immunotherapy. This is the latest thing. Okay. The major advantage of chemotherapy is it has an ability to treat widespread or metastatic cancer. If a cancer has spread to the different parts of the body, here comes the role of chemotherapy. Whereas surgery or radiation therapy, they are limited or they are confined to a specific area. You cannot do surgery to all parts of the body if the cancer has spread. If cancer has spread, you have to treat a specific area and put the patient on chemotherapy if there is a metastasis. Similarly, radiation therapy you cannot give to the whole part of the body. You give radiation only to the specific area or to the confined area. If there is a metastasis, then you give chemotherapy. I mean to say is that if the cancer cell has spread to the different parts of the body, if there is a metastasis, then you give chemotherapy. Let's start with chemotherapy. Okay. What is the definition of chemotherapy? The word chemotherapy itself says the definition. Chemo means chemical or drugs. Therapy means treatment. The treatment of cancer using specific chemical agents or drugs that are destructive to the malignant cells and tissues. The term itself comes from two words. Chemo means chemical, therapy means treatment. Now let's see how this chemotherapy works. Remember one thing very clearly. Chemotherapy destroys rapidly dividing cancer cells. Chemotherapy will also destroy healthy cells. Chemotherapy will destroy also healthy cells which are rapidly dividing. That means this chemotherapy drug is designed to destroy rapidly dividing cells. Which are the rapidly dividing cells? Cancerous cells, they divide very rapidly, abnormally. But these chemotherapy drugs, they also destroy normal cells which are rapidly dividing. Which are those cells? Cells of hair follicle, the mucous membrane of GIT from mouth till the GIT system. These lining of mucosal membrane, these cells also divide rapidly. And blood cells like lymphocytes, RBC, platelets, these are normal cells. So when you give chemotherapy, it will destroy abnormal dividing cancer cells. Also, it will also divide normal rapidly dividing cells. But these normal healthy cells will recover once chemotherapy has stopped. Sorry. What is the use of chemotherapy? As I told you before, chemotherapy drugs are used in cancer metastasis. Cancer which has spread to the different parts of the body. It is frequently used in conjunction. Conjunction means along with surgery, along with radiation therapy to ensure treatment success. So when you do the surgery, some remaining cancerous cells are there. Residual cancerous cells have been left there. In such cases, you give chemotherapy. If you do surgery, what about metastasis of cancer that has taken place? You remove cancer by surgery. Metastasis will be taken care by chemotherapy. And one more use is it is used initially. If a tumor is very big, you give chemotherapy to decrease the size of the tumor. The tumor will shrink down. It will be shoya size. Then you can easily perform surgery. So there are different methods of giving chemotherapy, like primary chemotherapy, adjuvant chemotherapy, neoadjuvant chemotherapy, concurrent chemotherapy, or palliative chemotherapy. Primary chemotherapy, in this primary chemotherapy, you give only chemotherapy. You don't do surgery. Only chemotherapy drugs will be given. Let's see other chemotherapy types. Adjuvant chemotherapy. What does the word mean, adjuvant? Adjuvant means assist, to help. Here in adjuvant chemotherapy, chemotherapy is given after surgery. First, you do surgery. This is a cancer. You can see an example. Metastasis has taken place. So first you remove the cancerous area by surgery, by resection. Then the question arises, what about the cancerous cells which has spread to other parts of the body? Here comes the use of chemotherapy. After surgery, you give chemotherapy. So in adjuvant chemotherapy, chemotherapy is given after surgery to clear microscopic residual disease. Then coming to neoadjuvant chemotherapy. Neo means new. Here chemotherapy drug is given before surgery so that the tumor or cancer will be reduced in size. The tumor will shrink. It will be easy to resect. It will be easy to do surgery and remove the cancerous area. It will also stop micrometastasis. It will reduce the tumor size, and also it will reduce tumor emboli at the time of surgery. That means when you do surgery, so your tumorous cells or cancerous cells will go through the bloodstream to other part of the body. If you give chemotherapy before surgery, it will reduce the tumor emboli. Okay. Next, coming to concurrent chemotherapy or chemoradiation, which is also called as chemoradiation. Here, chemotherapy and radiotherapy are given simultaneously. So, why do we give this? Because chemo agent first make the DNA of cancer cells weak. They will be susceptible to the damage or to the radiation. When we give simultaneously, what will happen? The chemotherapy drugs will make the DNA weak of the cancerous cells. It will ultimately destroy by the radiation therapy. Then there is another type of chemotherapy that is called as palliative chemotherapy. The word palliative means a drug or treatment that reduce pain without curing the cause of pain. Here palliative means you are just treating symptoms. Here the intention is not to cure the cancer, just to decrease the tumor load so that the patient will have a good life expectancy. You are just prolonging the patient. If the patient is very old, like 85 years, 95 years, in such case, you are just giving palliative chemotherapy to treat the symptoms. Here, the intention is not to cure the cancer. This is given in advanced stage so that the patient should have a dignified life, a good quality of life. Here, palliative chemotherapy is given to just reduce the pain or symptoms, just to improve the quality of life. I hope you can understand what I mean to say. So, what is the importance of chemotherapy for general dental practitioner? Remember my second slide where I asked you a question. What is the importance of chemotherapy for the general dental practitioner? Neither the dentist, nor the oral surgeon, nor the oral medicine specialty will prescribe chemotherapy drugs. This is not our field. But why we are studying? Because chemotherapy will produce certain oral complications. These oral complications are important for the dentist to know them, and they should know how to manage these complications. When a patient takes a chemotherapy, These chemotherapy drugs will produce certain complications, especially oral complications. Because of this, the patient will come to a dentist, and the dentist should know how to manage this oral complication. And remember one thing, any patient who is going for taking chemotherapy or radiotherapy, these patients will have a dental appointment. These patients are referred for dental consultation. Before they take chemotherapy, they will come again during chemotherapy, and they will come again after chemotherapy is finished. So if you are working in a hospital setup, you are bound to get this kind of patients. So what does chemotherapy does? Chemotherapy is a good drug that can have a very good role in treatment of cancer. But the problem with this drug is it creates or it gives lot of complication that includes oral complications also. One of the most important complications are bone marrow suppression. The blood cells are generated or produced in bone marrow, lymphocyte, RBC, platelets. If the patient is taking chemotherapy, there is a bone marrow suppression. That means there is a decrease in production of cells, leukocytes, erythrocytes, RBCs, platelets. If leukocytes are decreased in production, what will happen? The patient will have less immunity. If RBC or red blood cells are decreased, what will happen? Oxygen carrying capacity is reduced in the body. Then if thrombocytes or platelets, if they get reduced, what will happen? The patient with the normal clotting factor will not work properly. The patient will have a bleeding tendency. So patient will have nausea, vomiting. Why nausea and vomiting? Because I told you, these GIT tract, the mucous membrane of the GIT tract, these cells are rapidly producing. These are normal cells. As I told you before, chemotherapy will destroy rapidly dividing cancer cells, but it also destroy rapidly dividing normal cells. Hence, these normal cells are destroyed in the GIT. Hence, the patient will have nausea, vomiting, diarrhea, or severe sometimes ulceration in the stomach. The patient will also have dermatitis, anorexia. Anorexia means patient does not feel hunger. Then alopecia, there is a loss of hairs in the body, especially on the head. Then mucositis, there is an inflammation of mucous membrane. Then patient may be prone to have infection, fungal infection. This will be because of reduced number of neutrophils, lymphocytes. Hemorrhage because of platelets are being reduced. Then the patient may have xerostomia, that is dry mouth. Let's see one by one. The major important complication is there is a reduction in immunity. The neutrophils are reduced and patients are prone to have infections because this provides immunity to the body. So how do you manage patient before chemotherapy? Any patients who goes for chemotherapy will have a dental consultation. The oncologist or the cancer specialist will refer the patient to a dentist before he starts chemotherapy. So before chemotherapy, you have to give counseling to the patient, talk to the patient about chemotherapy side effects before they start chemotherapy. And remember, if the patient has any dental or periodontal problem, if you treat this dental problem or periodontal problem before the patient start chemotherapy, then there will be reduction in oral complication. That means that if patient who is going to take chemotherapy, if the patient has a lot of dental problem or periodontal issues, you treat this oral cavity before the patient take chemotherapy, then there will be reduction of oral complication. So management of patient before chemotherapy, you do the complete oral examination. That includes clinical examination, radiological examination, take OPG, IOPA. Then you do a good first dental prophylaxis. Do a good scaling, polishing, root planning, everything. If there are any teeth which are indicated for extraction, like unrestorable teeth, badly carious teeth, remaining root, or severe periodontal involvement, these teeth has to be extracted. Or if there are any teeth which can be saved by root canal treatment, you should start root canal treatment immediately. All surgical procedures should be done 10 days before chemotherapy starts. You should give sufficient time for the area to heal, and all major surgeries should be done 4 to 6 weeks, 1 to 1.5 months before they start chemotherapy. I hope it's clear. So now the patient may come for consultation during chemotherapy. That means patient has already started taking chemotherapy. The patient has started developing oral complication. Here the treatment is primarily empirical. Only symptomatic treatment should be done, and this treatment should be designed to improve patient comfort and to prevent infection. So during chemotherapy, the patient may have oral complication like mucositis or xerostomia. As I told you that the first and most important oral complication that may start first is mucositis. That is inflammation of oral mucosa. In such cases, you are not going to give non-steroidal anti-inflammatory drug. You are going plain analgesic paracetamol. Why you are not giving non-steroidal anti-inflammatory drug like brufen, diclofenac? Because brufen and diclofenac, they further cause gastric irritation, and patient may have severe gastritis or ulcers in the stomach. Hence you give simple analgesic, that is paracetamol. If need arises, if there is an infection, you can give antibiotics. And remember one thing, no elective dental treatment should be carried out. Elective means any dental treatment which can wait. It is not an emergency. Don't do those treatment. No elective dental treatment. Emergency treatment you can start, but emergency dental treatment should be done in a hospital setup. So if there is an emergency, the patient may need extraction of teeth or any surgical procedures. The first thing is that you need to consult oncologist and hematologist, and you should order complete blood count. The dental treatment should be carried out in a hospital setup. Absolute neutrophil count, you need to measure it. If neutrophil count is less than 2000 cubic millimeter, then the patient may be prone to have infection and septicemia. If neutrophil count is less than 2000 cubic millimeter, then antibiotic prophylaxis should be given. And you should also measure the platelet count. If the platelet count is less than 50,000 cubic millimeter, then the patient may have a severe hemorrhage. Don't do any surgical procedure, don't do extraction. First, the patient should have platelet transfusion, one platelet concentrate, that is 1 unit per 10 kg body weight. If there is a 50 kg man, the weight of a person is 50 kg, then he should have 5 unit of platelet transfusion. Understood? Okay. Now, how should be the extraction done in this patient? Atraumatic extraction. As less trauma as possible. Once you do the extraction, do the curettage of the socket, because there may be any remaining infection, granulation tissue left. Then do vigorous irrigation of the socket to clean the surgical bed and do a suturing of the wound closure. And antibiotic prophylaxis should be given before and after extraction. I hope it is clear to you people. Then coming to after chemotherapy, when chemotherapy has been completed, all the complication like alopecia, anorexia, or mucositis, these oral complication or other complications will be finished. If the patient will recover, the patient's hair will grow back. So after completion of chemotherapy, patient comes to you, you should consult the oncologist to determine how well he is immunity is working. Then do the good oral hygiene prophylaxis. Ask the patient to use chlorohexidine mouthwash. Okay. Then any elective treatment which you did not do, you can start the elective dental treatment. I hope it is clear. Now coming to radiotherapy. What is radiotherapy? It is a therapy using ionizing radiation, generally as a part of cancer treatment to control or to kill malignant cells. Here you are using ionizing radiation to kill malignant cells. Radiotherapy is mainly used in cancer treatment if the cancer is localized to one specific area of body or confined to one specific area. Then you use radiotherapy. It may also be used along with surgery or along with chemotherapy to prevent tumor recurrence. Understood? After surgery. So let's start with radiotherapy. Radiotherapy plays a major role in management of common cancer, either alone or along with surgery and chemotherapy. How does this radiation therapy works? Radiation therapy works by damaging DNA within cancer cells. This radiation therapy will directly damage the DNA of the cancer cells and destroy their ability to multiply. But by giving this radiation therapy, not only cancer cells are affected, but also normal cells can also be affected. But normal cells have ability to get repair itself. So radiation therapy or radiotherapy is defined as a treatment of diseases with ionizing radiation, generally as a part of cancer treatment to control or to kill malignant cells. What is the use of radiotherapy? to cure cancer or to reduce symptoms. How does it cure cancer? It destroys tumor which has not spread to other part of the body. If it has spread to other part of the body, or if there is a metastasis has taken place, then you have to give chemotherapy. If it is confined to a specific area, you give radiotherapy. To kill, also it is also radiotherapy is also given after surgery. Why it is given after surgery? When you do this surgery, you remove the cancerous area. There will be some residual Shoya cancerous cells remaining. To remove these cancerous cells, to kill these cancerous cells, residual cancerous cells, radiotherapy is given. The other use of radiation therapy is to reduce symptoms. If tumor is very big, you give radiation therapy so that tumor shrink or reduce in size. Sure, this tumor you can easily operate later on. So when the tumor shrinks, the quality of life will improve. It will also reduce the pain by reducing the size of the tumor. How does the radiotherapy works? The mechanism of action. Radiation therapy works by damaging the DNA of cancer cells. When these cells are damaged, they destroy their ability to reproduce or to multiply. This ionizing radiation, you can see, directly damaging the DNA cells, directly or indirectly. Directly, you can see here, it will damage the DNA strand itself. Indirectly, how does it damage? This radiation will react with water in the cells. Our cells also have water. When radiation is given, what will happen? This radiation will react with water to produce free radicals. These free radicals indirectly damage the cancerous cells. So, indications of radiotherapy. If the cancer is in stage 1 or in stage 2, you can either do by surgery or by radiation therapy, either one. If the cancer is in stage 3 or in stage 4, you can do combined therapy. First you do radiation therapy, first you do surgery and you remove the cancerous area, then residual or Shoya cancerous cells which are remaining, for that you give radiation therapy. This is most of the cases we do it. We remove the cancerous part and whatever residual cancerous cells are remaining, you give radiation therapy. Then coming to in stage 3 and stage 4, chemotherapy is also given in some selective cases. And there are some cases where we give only radiation therapy, primary radiation therapy. If the cancer is in early stage, Shoya cancer, very early stage, patient will not prefer for surgery because there will be cosmetic defect, functional defect. So to avoid functional and cosmetic defect, you give radiation therapy. If the cancer is very big and it is very near to an important anatomical landmark, important anatomical area, it cannot be resected. Sorry. In such cases, you give radiation therapy. And radiation therapy is also given in high operative risk cases. Means patient is very old or patient is very medically compromised. Surgery is not an option. Patient cannot stand surgery. In such cases, we give radiation therapy. And radiation therapy is also given when recurrent surgery, many surgeries have failed. There is a recurrence of cancer. In such cases, we give radiation therapy. And sometimes the patient themselves prefer radiotherapy instead of surgery, but in stage 1 and stage 2. where only radiation therapy is given. There are different types of radiotherapy. First is brachytherapy, that is also called as internal radiotherapy. This is a Saudi board question they had asked for me. So what is internal radiotherapy? Surgical implants of radioactive source placed in the tumor. What we do is that we place a radioactive material inside the tumor. Most preferably, iridium implants are commonly used. This iridium is a radioactive material you place in the tumor. Then you give the radiation. What is the purpose for this? So that high dose of radiation can be given to the specific cancer area and minimizing dose to the normal surrounding tissues. Only that area get radiation. And there is another type of radiotherapy that is called as teletherapy, that is also called as external beam radiotherapy. Here the source of radiation is at distance from the body. You can see brachytherapy for a lip cancer. Your radioactive material is placed in the cancer of lip so that only this area get high dose of radiation while minimizing surrounding area the radiation dose. I hope you understood this. So when there is a radiotherapy given, the body may react differently. There will be two tissue reaction to the radiation therapy. So let's see what are the different complications the patient face when there is a radiotherapy given. The first is radiotherapy to the and skin. Here usually there is an acute skin reaction, or it is called as radiation dermatitis. Radiation dermatitis means derma means skin, itis means inflammation. Acute skin inflammation will be there. This radiation dermatitis is a side effect of radiotherapy. It is also called as radiodermatitis. It is confined to the area of skin that has been irradiated, where radiation has given, and this skin changes, whatever the skin dermatitis changes is sharply demarcated. Only the area where radiation is given you will see this dermatitis, and the other area where the radiation dose is not given, it can be sharply demarcated. And some patient may have delayed skin and subcutaneous damage like telangiectasia. You can see below the skin fine thread like or spider web like veins. There is a dilatation of small arteries, capillaries, veins you can see, and you can see this in normal person also, a person who is very fair. So this is a delayed radiotherapy complication. Telangiectasia is a condition in which there is widening of veins or small tiny blood vessels. They cause a thread-like pattern, red thread-like pattern. They usually occur in cluster. They are also called as spider webs because they look like a web of a spider. But once the radiation therapy is completed, the patient's skin will become normal. Then coming to mucous membrane, how does radiation therapy or radiotherapy will give complication to mucous membrane? There will be severe mucositis, inflammation of the mucous membrane. Okay, this will cause damage to the basal layer of the epithelium. When there is a damage to the basal layer of the epithelium, what will happen? There is a pseudomembrane formation will take place. Sometimes there will be ulceration in the oral cavity. Next is xerostomia. So whenever radiotherapy is given in near the oral cavity, which this radiation therapy may damage all the salivary glands, and the production of saliva is reduced, and it will cause dry mouth, which is also known as xerostomia. In xerostomia, what will happen? There is a dry mouth, there will be thick secretion, the saliva will be more mucus than serous, the patient may have increased gag, the patient will have difficulty in wearing dentures if he is a denture wearer, the patient will have difficulty in speaking or swallowing because of the dry mouth. So doses, if they are more than 300 centigrade, this is CGY, this is the unit of radiation. If the dose is more than 300 centigrade, it will pose a risk to all major salivary glands in the field of radiation. Whenever the radiation is given, if the dose is more 300 centigrade, it will cause damage to all major salivary gland. If the dose is more than 6000 centigrade and given for 5 weeks, there will be irreversible damage and the patient may have xerostomia for throughout his life. Another complication is taste disturbance. If dose is less than 2000 centigrade, there is a decrease in taste activity. Patient cannot appreciate food, taste, sour, salt, bitter, because you must have heard or experienced during corona period, whoever was infected by coronavirus, there will be decreased in taste perception. And if the dose is more than 3000 centigrade, the patient will have complete loss of taste sensation, that is called as ageusia. But this will recover. These are normal cells, they will get damaged, they have an ability to recover. After 60 to 120 days, the patient will have a complete recovery. But if the dose is more than 3000 centigrade, then patient may have complete subjective loss of taste. Then the patient may have anosmia. Anosmia means decreased ability or loss of ability to perceive smell. It is commonly seen during radiotherapy to nasopharyngeal and maxillary sinus tumors. Whenever there is a nasopharyngeal or maxillary sinus tumors, if radiation therapy is given, anosmia is common. That is loss or decreased ability to perceive smell sensation. Then there is another complication, radiation caries. This radiation caries is precipitated by changes in the saliva and nutrition. Generally, typically these caries affect gingival third or incisal cusp of the teeth. You can see it here. These caries may be, radiation caries may be because of the lack of production of saliva. There is a xerostomia. If there is a lack of production of saliva, what will happen? There is a shift towards carcinogenic flora. Those microorganisms will grow more in oral cavity, which are prone to produce caries. Understood? So the typical example for this is gingival third and incisal cusp of the teeth. Here there is a caries, which are known as radiation caries. Again, this is a Saudi board question. Then there is radiotherapy induced oropharyngeal candidiasis. Whenever there is an immunity has been reduced, opportunistic infections in the oral cavity will take place. Most commonly candidiasis that typically affects tongue, oral cavity, labial commissure, and they are in form of three types: pseudomembranous, atrophic, or angular cheilitis at the corner of the mouth, you can see. The usual appearance is a removable white lesion which can be easily scrapped. They lie on the erythematous or atrophic patch. You can easily scrap them. Another severe complication, trismus. When you give radiation to the head and neck cancer, so what will happen? Trismus occurs due to contracture or fibrosis of muscles of mastication. Whenever there is a radiation to these muscles, contracture and fibrosis of the muscles takes place. So irradiation muscles become more fibrotic and they tend to contract. Hence, radiotherapy produces trismus, difficulty in opening mouth. And most severe complication you can see is osteoradionecrosis. What is osteoradionecrosis? Osteo means bone, radio means radiation, necrosis means death of a bone. Okay, necrosis of bone occurs secondary to radiation. It is most commonly seen in mandible. Like 95% of the cases are seen of osteoradionecrosis is seen in mandible. The posterior mandible is most commonly affected, and these patients where osteoradionecrosis has been taken place, these mandible are prone to fracture, that is called as pathological fracture. You can see the mechanism here. Whenever there is a radiation to the bone, what will happen? In the bone there is hypocellularity. That means less nutrients or less minerals are will be passing to the cells. Hypovascularity, reduced blood supply will take place. Hypoxia, reduced oxygen will be taking place. So all these factors may lead to reduced capacity of bone to recover from injury. Here, normally when you give radiation to the bone, osteoradionecrosis does not take place. It will take place whenever there is an injury. Whenever there is an injury like extraction, so healing will take lot of time. There is a reduced capacity of the bone to heal because of hypocellularity, hypovascularity, hypoxia. So these area will not heal. It may lead to osteoradionecrosis. The problem with osteoradionecrosis is that there may be this area may get super infected with bacteria or fungus, or there will be sharp bony spicule which is not healing, and this may traumatize the normal surrounding tissues. Okay, then we will see most important thing, management of patient before radiotherapy. Many cancer surgeons, before they give radiation therapy, they refer the patient to a dentist. What are you going to do if a patient has come for consultation before he takes radiotherapy? Dental treatment should be done immediately. You should not give appointment as you want, because the patient is having cancer. Okay, it must not be delayed because cancer is progressing. And remember one thing, many of the complications that are seen during radiotherapy will be reduced if you do the treatment, or if you remove any oral disease or periodontal disease before radiotherapy. That means if you treat or you manage oral diseases before the patient goes for radiation therapy, there will be less complications seen in the oral cavity. So when this patient comes to you, what are you going to do? You are going to consult, you are going to do a good patient oral hygiene. You are going to explain to the patient how to maintain a good oral hygiene. You are going to clinically examine hard and soft tissues. You are going to take x-rays and do radiological examination. Any teeth which are supposed to remove, you remove it. And another very important thing which a dentist has a role to play, making radiotherapy prosthesis. You see, radiotherapy prosthesis. Here I have given an example. The patient has a tongue cancer. So you are going to give radiotherapy to the tongue. So you make a tongue positioning device. Only that part of the tongue which protruded out where the patient is going to take radiotherapy. Other areas is protected by lead shielding device, so that the other normal area or normal oral cavity, the patient will be protected by radiation therapy. So patient education is very important before the patient take radiotherapy. Patient should be made aware about all these side effects and complications that the patient is going to encounter when he takes radiation therapy. And you should teach him how he is going to manage. You are going to teach him all the good preventive oral hygiene methods, how to brush, how many times to brush, use soft bristle brushes, and any diseases, oral diseases or any dental treatment is required before the patient take radiation therapy, like extraction, filling, oral prophylaxis like scaling, or if the patient may have sharp teeth. All these treatment has to be done before the patient takes radiotherapy, even fluoride application. And what is the criteria for extracting a teeth before he takes radiation therapy? It should be badly carious teeth, unrestorable teeth, remaining root. There is an preapical infection, active preapical disease, which is symptomatic, moderate to severe periodontitis, even moderate also to severe periodontitis. Teeth are involved, then you extract it. If there is a lack of opposing teeth are not there, if there is a patient has a compromised oral hygiene, remove it. Partially impacted or incomplete eruption of a teeth, because this area have pericoronitis, even such teeth has to be removed. If the patient has an extensive preapical infection or lesion, remove it. But remember one thing, deeply impacted teeth which are not having any symptoms should be left alone. It is better to avoid surgical extraction unless and until it is needed. So extraction you should perform in such a way, you should give sufficient healing time before radiation starts. The accepted interval is 2 weeks, that is 14 to 15 days. Once this area has healed, then the patient can start radiation therapy. Sometimes you are in doubt, like whether to extract or not to extract. Even in clinics also, you usually ask for a specialist to come and see for consultation, whether to extract or not to extract. Different specialists will come, different opinion will be there. In case you are in doubt whether to extract or not to extract, it is better to do extraction in these radiotherapy going patients. It is better to be on the side of error and better remove the teeth. Understood? What are the guidelines for extraction? It should be performed 2 weeks before radiotherapy. Once you have done the extraction, trim the wound margin of the bone. There should not be any sharp edges, and a primary closure should be done with suture. If the platelet of the patient is less than 50,000, don't do extraction, do the blood transfusion or platelet transfusion. As I told you before, 1 unit per 10 kg. If the patient is 50 kg, 5 unit of platelet transfusion should be done. If the WBC count is less than 20,000 cubic millimeter, don't do it. And when the patient's count has increased, do the extraction, but give prophylactic antibiotics. Because whenever there is a reduction of neutrophils, what will happen? There will be reduction in immunity. The chances of patient having infection will be more. So it is better to give antibiotic prophylactically is recommended. Management of patients during chemotherapy. Chemotherapy has started. Patient is taking chemotherapy. Now patient will start coming to dental clinic because of the oral complication. First thing is that no elective dental treatment should be carried out. Elective means those dental treatment which can wait. Only emergency extraction should be done. Only in this period you have to do symptomatic treatment, that is management of any complications. Advise the patient to avoid alcohol, avoid smoking. Patient should not eat hot food or spicy food, and also patient should not take alcohol containing mouthwashes. But alcohol containing mouthwashes are not available in Saudi Arabia, but in other parts of the world there are mouthwashes which has shoya amount of alcohol. So maintaining good oral hygiene is very important. The patient should rinse in a solution of water and sodium bicarbonate 3 to 4 times a day to clean his oral cavity. This mouthwash containing sodium bicarbonate is effective to relieve, to treat mucositis induced discomfort. So many of these patients who are getting radiotherapy, uh, they have a important and first complication is inflammation of oral mucosa, severe inflammation. Here you can use sodium bicarbonate. One of the main advantage of this mouthwash containing sodium bicarbonate with water is it is can be prepared at home. This sodium bicarbonate is nothing but baking soda which you use to bake or make cakes and all those things. You use this in food. Okay, and it is easily available at home. The patient themselves can prepare it and it's very cost effective. This will have a very good effect in relieving mucositis. Then patient should use fluoride like 0.4% standard fluoride gel or 1.23 percentage of APF gel and place on a fluoride carrier and put it on their dentition for at least 5 minutes. How long should you use this fluoride? Some of the papers which I have seen that they have recommended any patient who takes this head and neck radiotherapy, they should use fluoride throughout their life. Anyway, coming to they should brush and keep their oral cavity, brush their teeth with soft, very soft bristles, not to damage the gingiva and oral cavity 3 to 4 times. Then another management of this mucositis is that can use lanolin, a petroleum jelly, is like a Vaseline on their lips to make it lubricant. Patient, if there is a severe painful mucositis, patient cannot eat food, then they can use topical anesthesia. Viscous lidocaine is available. They can just spray in their oral cavity before they take food. And another topical analgesic like benzodiazepine hydrochloride is available. This benzodiazepine hydrochloride very significantly reduces mucositis in head and cancer patient. You can use 15 ml in a tablespoon. 1 tablespoon has 15 ml, and take it in oral cavity, gargle it and spit it out. Gargle it for at least 30 seconds, they say. This has a very good effect. This medication will give relief to the pain and inflammation in the mouth. It's commonly used for those patients who are undergoing head and neck um, radiation therapy. Then there is a management. These patients have xerostomia. As I told you before, radiations and head and neck area will also damage all major salivary glands. When major salivary glands are being affected, there is a reduction of saliva production. If there is a reduction of saliva production, the patient will have xerostomia. So in such cases, you can stimulate whatever remaining saliva is there by use of cellulogs. These cellulogs are the drugs which can what you call parasympathomimetic drugs. These drugs are given so that saliva production is increased, especially pilocarpine 5 mg, which should be given 4 times a day. This pilocarpine, it is a parasympathomimetic agent. This is the only drug. This pilocarpine is the only drug approved by FDA, which is used as a cellulog for radiation-induced xerostomia. Then there is a palliative treatment for xerostomia. Palliative means just symptomatic. Patient can take mouth wettening agents, frequent sipping of water, or they can take carboxymethyl cellulose. This carboxymethyl cellulose is nothing but an artificial saliva. So that if the patient has severe dry mouth, they can take it frequently to keep their mouth wet. Then coming to immunity. These patients who are taking radiotherapy are prone to have fungal infection. If there is shoya fungal infection, topical miconazole, fluconazole, or nystatin can be given. If there is a severe fungal infection, then tablets in the form fungal antifungal drugs in a form of tablets, nystatin or miconazole can be given. If candidiasis is severe and it cannot be cured by topical application, then the patient may go for uh, systemic therapy in form of tablets. Nystatin and mecanozoles are quite effective. Then there is a severe trismus because of fibrosis of muscles. The patient can go for physiotherapy. There are some electronic machine. You can see here a lady having a mouth opening device where the physiotherapy is shoya, you can try to make the mouth open. During our times, we used to make this with acrylic. You can see this is screwdriver. Every day we used to increase one round. The more you increase, the more the tooth will become widened. But I don't know whether these days we use or not. And we can also give tricyclic medication for trismus for these patients. If there is an emergency extraction, what are you going to do? If there is an emergency extraction, it should be done in hospital setup. And one thing is important is that radiotherapy should never stop. You should consultation should be done with the radiation oncologist before you do the extraction. Extraction should be done atraumatic as possible with minimum trauma, and it is better to be done by an specialist. Management. Once the radiotherapy has been completed, the patient may come again to you. All the acute oral complication has been resolved or gone. The dentist should ask the patient to maintain oral hygiene, oral exercise, because there was a trismus. The dentist should help the patient to in opening the mouth, to increase his opening of the mouth. Okay, and this is the excellent time. Whatever there was a elective treatment which you did not do during radiation therapy, this is the right time to start radiotherapy. Okay, this is the right time to start dental treatment. Then long-term recommendation. The patient should be reviewed after 3 months after finishing of radiotherapy. See whether there is any new pathology has taken place or recurrence has taken place. Once everything is clear, then you can start making this prosthesis, because this area had been resected. Okay, if the patient can go for reconstruction, plan it with the surgeon. If reconstruction is difficult, then you can make maxillofacial prosthesis. This is the right time. Now coming to the last slide, extraction performed after radiotherapy. Remember, very good slide and very important thing to think about it. Many patient comes to our oral surgical clinic. They give history that radiotherapy was done 5 years back, 2 years back, or 1 year back. They, in such cases also, remember, there is a chance of complication of osteoradionecrosis. Some cases where radiation was given 20 years back, extraction was done, it has led to osteoradionecrosis. In such cases, automatic extraction should be done. If there is a multiple extraction, don't remove many teeth at a single time. Remove 1 or 2 teeth, allow that area to heal, give a window period of healing, then go for another extraction. According to the research, some of these systematic reviews which I have seen, the best time to do extraction is after radiation therapy is first 1 to 6 months. This is a controversial, many people do not agree it, but as I have put a latest article here, we can discuss in the class why only first to 6 months the chances of osteoradionecrosis is reduced. This is why this is a safe time frame. We can discuss this later. All is this about your chemotherapy and radiotherapy class. Sorry, I must have taken Shiva more time. You have any doubt, you can message me, WhatsApp me. If you want me to take class, if you can arrange, I can come and take class. Even if it's for few students also, I would love to take this class. Okay, all the best. Thank you. See you in the college. Assalamu alaikum.